Good afternoon, everybody. I can see some people waiting to connect to audio, so I'll just give a couple of minutes. Couple of seconds. Right, hello, good afternoon, everybody, and thank you for joining us. Welcome to the What Digital Data Means for the Future of Falls Prevention webinar. My name is Adam Hunt, and I'm the Digital Transformation Lead for the National Care Forum. We support the not-for-profit care sector with over 165 members who deliver social care in all its many different forms. And I'm really pleased to see today just how much interest this webinar has generated. We're very proud to be delivering the session today with one of our forward-thinking partners, Nourish. And trust me, you're in for a very interesting session. So if I can first ask you all to please pop your name and organisation into the chat box, which you should find on your toolbars below. And that'd be great, because then we get to find out who you are. And so it's our form of an icebreaker there. And also, we will be recording this session. It will be shared afterwards. And please feel free to turn your cameras off if you do not wish to be featured. And can also ask if you can pop yourselves on mute as well. That would be fantastic. So Falls, why we're here, Falls. And I know I'll be preaching to the converted here for many in the sector already, but they have a huge impact. The impact on an individual's physical and mental well-being, their loss of confidence and increased fear of falling again, that these are factors that can cause a person to withdraw. That impact is felt in care and support teams with associated like escalations of need, or that feeling of frustration where you feel that that fall could have been preventable. The family whose anxiety around their loved one is increased, and additionally the impact on health and hospitals, which is costly. So between 2017 and 2018, around 220,160 emergency hospital admissions alone were related to falls among patients aged 65 and over. And drilling down deeper, the statistics shows that people who live in care homes have an increased risk of falling. So how is this being addressed digitally and in the sector? So the Digital Health and Care Plan, published in July this year, it brought together those aims and ambitions from people at the heart of care and Join Up Health and Social Care, with a commitment to digitising parts of the sector, with two major targets that are to provide 20% of those most at risk of falls with sensor-based falls detection / prevention technologies, and to provide 80% of CQC registered providers with a digital social care record system. And both targets are set to be achieved by 2024 and are being delivered through ICSs. So the targets highlight a need to support quality care and address falls using technology and tools that can facilitate that move, not only from paper to digital, but from that reactive to that proactive. And that reduces that burden on teams and opens up opportunities to make informed and data-led decisions. So this webinar is going to begin with an exploration of Action Falls programme with Dr. Fran Allen, a research fellow from Nottingham University, before we'll be handing over to Jeremy Baldwin, Nourish's Chief Product Officer, who'll take us through how Nourish's software is that powerful tool in the collection analysis of important care data. And it'll be moving that information into action, essentially. We then have a slight change of plan, as unfortunately Nuno from Nourish is unable to join us, but Jeremy will be continuing the conversation as we look into the future. And this, I am sure, will provoke a lot of thinking and hopefully a lot of questions for a Q&A with the panel at the end. So before handing over, please feel free to drop any questions into the chat as we go along, and I'll be looking to bring them in with the panel at the end, and enjoy. So I shall now hand over to Fran, who's going to begin our journey. Over to you, Fran.
Brilliant. Let me just see if we can make the technology work, which is always the fun bit. There we go. Right, I'm hoping everyone should have a globe and some writing and my name. Do shout if you haven't. Okay, so well, good afternoon, first of all, and thank you to Nourish and NCF for inviting me to talk today about some of the research we've been doing on falls in care homes. As Adam has kindly introduced me, I'm a research fellow at the University of Nottingham, and I'm also a physiotherapist with a long clinical background. And I'm now study coordinator for the Falls in Care Home implementation study, which we'll talk a little bit about in a minute. So the first thing I wanted to say was, and again, Adam has already addressed some of this, is why falls and why care homes? Well, falls are a big problem in care homes and for older people specifically. 1 in 3 adults over the age of 65 and half of those aged over 80 will fall in any given 12-month period. And in care homes, that's 3 times more frequent. So it's a really big problem. And at least 40% of injury deaths that occur in care homes are due to falls. And largely this is because 1 in 10 care home residents who fall will sustain a fracture and or a break of some kind. And this has various effects on people within the care home. So the staff will have a certain amount of anxiety around falls and fears of litigation. And this can actually stop, create sort of caution around allowing people to exercise and be mobile within the home. But also this has a dramatic effect on the individual who falls. It can be a life-changing event, not least because of injury, but because of the psychological problems that a fall can cause. It causes a loss of confidence and a fear of falls. And then this becomes this cycle of decline where people are worried about falling, they become more dependent and less willing to mobilize. And then you sort of get this sort of weakness and frailty, increased frailty coming in, which of course increases the risk of falls. And coupled with this is the fact that 60 to 80% of residents, as you probably know, will be cognitively impaired in some way or have a diagnosis of dementia. And this in itself creates an increased risk of falls. But so how do we prevent these falls, and what have we been doing at Nottingham to help prevent falls in care homes specifically? In 2003, I think it was, so sort of getting on towards 20 years ago now, a lady called Kate Robertson, who some of you may know or have heard of, and the team at Nottingham University created the Action Falls programme. Now, I do just need to say that we have had a name change. So originally, this tool was called the Guide to Action Care Home, or the GTAC. But what we know from doing some of the research previously and from talking to care homes was that the name GTAC really wasn't great. People didn't really like it because it was hard when you had to sort of do handovers to GPs or, you know, ambulance staff or hospitals. To say GTAC didn't really explain what it was. So in consultation with care homes, we've changed the name to Action Falls. So some parts of this you will hear the term GTAC, and some you'll hear Action Falls, depending on when the work was done, but it is exactly the same thing. Okay. So the Action Falls programme is a multifactorial programme consisting of lots of different elements. The main one being currently paper-based, and and partly why we're here is we're looking at whether digitisation of the tool would be preferable and how we can do that. But it's a falls risk checklist and decision to support tool. So I'll talk a little bit about that in a minute. But it also encapsulates staff training and support to use the tool, mobile application to give information. We've also got a website, support to create a falls champion role to help sort of create this culture of falls prevention, and then some written material, a reference manual, and a falls awareness poster. Now, what makes this tool different from some of the other tools? Well, partly it's because every residents get assessed regardless of whether they've fallen. This is designed for every member of staff within the care home to be trained in falls. So, you know, we're looking at, you know, the maintenance workers, kitchen staff, housekeeping staff, everyone to have this understanding of falls, and again, to create a culture of falls prevention across the home. And it doesn't just classify someone as having a risk, it also tells you what to do about that risk and gives you help and guidance in preventing falls for the individual. So, and this comes within the Action Falls checklist. So this is how it looks currently. So it's a paper-based tool. And again, we're looking at whether this can be transferred into electronic format, because I realise that's a growing area. But basically, you go through all the risk factors and you mark off which ones are specific to the individual. There is then a second column which tells you what to do about those risks if you find them. And then the key thing is that someone signs off to say that they've been addressed. And so it gives you this support and a guidance through falls assessment. So what we did was the Action Falls was created, and then we took it to clinical trial. Randomized clinical trial was completed, and it's the biggest trial that ever took place in the UK in care homes. And 84 care homes took part, of which 45 of the care homes carried on with normal care, and we looked at their falls rates and various metrics within the residents. And then 39 care homes did all the usual things you would do, but also implemented the GTAC Action Falls. We also recruited within those homes 1,657 care home residents. And the GTAC training or Action Falls training was delivered to 71% of staff in those 84 care homes. But we also know that introducing a new tool or a way of working is nothing without the involvement of staff. And therefore, we also talked to a lot of members of 88 members of staff about what the barriers and facilitators were to implementing this program, and what was good and what could be improved in the future. Well, the results of the clinical trial were really, really positive. Those care homes that used the GTAC Action Falls program reduced falls by 43%. But not only that, was using the tool didn't affect residents' activity and dependence levels. So it wasn't a case of stopping people moving around, which made them safer and they didn't fall. They were still just as active as before, it's just that they didn't fall as much. It was also cost effective. It cost £108 per resident, but when we look at things like the cost of falls, lost income, cost to health and social care, and the cost associated with residents becoming more dependent because of fear of falls, this was actually deemed to be a very cost-effective amount. Losing my notes. However, in practice, we know that clinical trials run very differently to sort of everyday care. So that our next step along the research journey is to look at how we can embed the Action Falls programme in actual care in real care homes, on a day-to-day basis. So we're currently halfway through the Finch implementation study. We're working with care homes in 4 English regions. So we're working in the North East, the West Midlands, the East Midlands, and South London in Bromley. And we're working with 60 care homes who are implementing the Action Falls programme for 12 months. We're asking them to use it, but then we're also then talking to care homes about their experiences of using Action Falls. And this we're doing through creating collaborative peer support groups where we get everyone together to talk about what's going well and what isn't, and then we're adapting it in real time for them to use following these events. But then we're also, to get a real breadth of what staff think, we're using questionnaires and interviews to get this, like I say, this real breadth of understanding about what it is to have this tool implemented. And by the end of the study, we aim to use this information to create a toolkit about how to implement, how to take on the Action Falls programme, And this is going to be for whether that's, you know, care home managers, owners, health and social care, people running services, commissioners. So we're going to have this a toolkit that's adapted for lots of different people at different levels. However, we realise, as we've mentioned before, that care documentation particularly is changing. And where Action Falls in 2003 was designed to be a paper-based program, it's definitely, you know, we're now exploring ways in how it can be digitized and how we can move on and how that can fit in with a more digital landscape within care. And just really to sort of finish off, the bits I was going to say is just, if you want more information, if you want some more guidance about falls prevention, I've put up the resources there for the React to Falls website and the React to Falls app. These are resources that have been designed by the Action Falls Finch team at the University of Nottingham, so they very much reflect what's in the tool. And like I say, that's all free to use and free to download if anyone wants to have a look at that for some more falls prevention advice. If you want to talk to us about the tool itself, or the research we're doing, or to, you know, to see if you can be involved with that, I've put our email address at the bottom, and I think the slides are going out at the end, so you'll be able to come back to that. But please get in touch. We're happy to chat. You know, we're happy to send some more information out to you. And that is a bit of a whistle-stop tour. We've done a lot of work. There's 20 years of work in that. So and we're sort of carrying on, but we're all always keen to talk to you know, care providers, care home staff, anyone who's interested. Do get in touch, because it's only through talking to everyone that, you know, we can improve the tools. So thank you for listening. I think we're going to do questions at the end, so have a think about that, and I'll hand over to back to Adam, I think.
Thank you very much, Fran.
I'll stop sharing.
Brilliant. Thank you very much. No, that's brilliant, and hopefully we'll get some questions into the chat. So please feel free to be posing them throughout. I have had a couple through, so I am saving them for the end. But yeah, keep them coming. So shall we hand over to Jeremy now, who's going to take us through Nourish and how it uses data to inform these decisions. Over to you, Jeremy. Thank you very much.
Thank you, Adam. Thank you, Fran. Everyone hear me? Adam, shout if you can't, because I'm sure you can. And you're seeing my screen, which is fantastic. So we're all good. Thank you, Fran. Thanks for that. You know, it's really good to get a view of how research is supporting falls prevention. And I guess what we're trying to do now is take a different look at that and understand how perhaps digital, and importantly the data that comes off the back of digital, is helping to support falls reduction now and potentially falls prevention in the future. And we sort of go on to then look at how perhaps a combined approach between research and digital and data is possibly the best way forward. So I'm Jeremy Baldwin. I head up the product team at Nourish, so responsible for all the future design and development of where we go. Just in terms of, I know there's a number of our customers on here, a number of people that already use Nourish. So welcome, thank you, we love you all. But there may be a few of you who don't know who Nourish are, so just very, very quickly, just a very brief introduction to Nourish. Nourish is a digital care platform. We've helped thousands of digital care services to make a transition to digital care planning, to recording digital or having digital care records. And we support configurations in a very wide variety of social care settings, including residential care. At its very simplest form, it is a point of care app that gives your care teams access to information about the individuals you support, the critical information that you need to know about those individuals, and a daily timeline of the care tasks that need to be completed to be able to deliver on their needs. By recording, using that app, by recording the interactions and other events that happen with that individual through the day, you get a near-term view of all the things that have and all the things that haven't happened, with all the necessary communications and escalations to make sure that the full care team is involved and any necessary interventions happen, and a management app that's for the planning of personalised care and the overseeing of care quality in your service. And perhaps really importantly for what we're going through today, we have the means to use the data that's collected with a series of data tools to analyse that data to better support decisions. So just wanted to give a very brief overview as to what Nourish is, and clearly everything that we're talking about today is based on how our customers and the future of our platform will help to support digital and data contributing to falls reduction. As both Adam and Fran have detailed, so I'm not going to go through it again. We're all here because we know that falls are an important issue. We know that reducing falls and the impact of those falls on the individual has a significant influence on the quality of life for those that you support. We accept that some level of falls are always inevitable. We know there are a number of common risk factors and ways to mitigate those risks, which Fran has clearly been through, and their research project are massively focusing on. But we also know that those triggers, those influences, those mitigations, more often than not, tend to be very specific to the individual, all of which goes together to say what we all know, which is that the managing of falls is a very complex issue. It's multifactorial. It involves lots of different things in relation to that individual. So perhaps before going into the specifics of digital, I just wanted to set the scene, just in terms of what is the falls management workflow, which of course we all recognize it's pretty much the same regardless of the kinds of systems that we're using. That consists of a number of different elements. It is about understanding the risk, usually done through some level of risk assessment. So understanding the individual needs and risks of the individuals that are being supported, and some means of responding to that in terms of their care plan or the delivery of care. So the kind of mitigations and hyper-personalized response that Fran's been talking about. There's a means to monitor and record those tools, processes to be aware and to record that falls have happened. There is some form of response, an immediate response to the fall itself. As we've already talked through, they can have quite substantive impacts, wounds, etc. in a very short term. They may require some level of transfer of care, for example. But what is that immediate response, and any post-fall observation and any changes to care that might happen in near-term changes to care that might need to happen in response to that fall. Some level of analysis happens. We need to try and understand the root causes for those particular falls, and we'll tend to do audits across our services in terms of what's happening in terms of falls. Do we understand what's happening in terms of falls? What kind of levels of falls do we have? A time-intensive task, which is part of the issue, but there is some form of analysis. And then we try and use that analysis for care improvement. How do we change that individual's care? How do we change the environment, or make changes to the environment, changes to process, or perhaps changes to the skills of the people that are supporting those individuals as a response to understanding what's happening in relation to that. Some of the issues there, I guess, is we are still dealing very much with generic risk factors. It is reactive. We do tend to be looking at historic data. We do tend to be looking at what has happened. There is therefore very much an emphasis on reducing falls, which can slip into a bit more of a governance and compliance conversation than a care conversation. We get these wonderful terms of information creep and sprawl, but basically just meaning that we've got lots of bits of information in lots of different places, and it's a pretty closed loop. It's a loop that involves that specific set of people in a specific context and doesn't necessarily go wider. Not all of those things are a problem, but it's an observation we need to make. So in terms of how digital and data is currently being used to support that workflow, or what and how it can continue to do so. I'm not coming here with a claim that there's some sort of magical digital solution for reducing falls, certainly not one that replaces a level of personal intuition and intervention. But we do know that digital and data does have a significant role to play. Our intent in what we're showing today is to show how currently digital and data is being used, and a view on how those digital systems and that data can contribute to a reduction in falls in the future. And all of that based on our observations and analysis of those using our system. Now, it's not, clearly Nourish is not the only digital system. There's lots of different parts to a digital system that need to be contributed. We certainly don't have all the answers. And this is very much a two-way request too. This is we really want to hear your experiences, your ideas, your perspective on where digital can help, either in the comments and questions today or perhaps later on. Okay, so how is digital currently being used to support falls? If we look on the risk assessment side, we are recording the falls risk. We are able to do those kinds of assessments, and as we've said and as Fran's highlighted, their assessment may become part of this picture, but there are clearly others that exist. There are others that exist within Nourish and other digital platforms. So we're doing those risk assessments digitally. We're recording them digitally, and not only are we doing the falls risk assessments digitally, we're doing all other assessments of risk digitally as well. So we get a much stronger picture across the whole set of needs of a particular individual. And that, to a degree, allows us some level of automation of change, of identifying those risks, and some level of automation to change potentially a care plan or a care schedule for that particular individual in relation to those specific risks that may have been identified. In terms of monitoring and recording, lots going on. Clearly, fall detection and remote monitoring technology is something that is a heavy investment. It's something that's been identified as one of the key areas in the future digital plan. And many of us will have those in place or are looking to invest in having those in place. That's in combination with other factors, just use of email, use of other factors to be able to do automated fall alerts, so that we get better awareness when falls are actually happening and can therefore potentially respond quicker. We know that the quicker the response to a fall, the more likely it is to be a lower impact on the individual. Having that data in that way means we can start to show it through things like dashboards, which I'll go on to in a minute. And we're also recording the fall itself, or the occurrence of a fall, and the other care, and really importantly, the other care events that have happened around that fall digitally. So we have all of that data available to it. That data is not something we have to actively go and look for. That data is something that comes as a natural part of the fact that we are recording those things digitally. From a response point of view, again, we're digitally recording the response. So how have we responded to that? What is the response? What has been an impact? What other things have happened in relation to that particular fall? And we can start to do some really good stuff around automation. So we can start to say, okay, we can automatically do things like falls observations and make sure that those are put in place. If there is a wound, make sure those kind of wound protocols are put into place. If there is transfer of care, how that transfer of care and information is going across in the right ways. Is there any mandatory reporting that needs to be done, etc. Can all be automated through digital systems. The really exciting bit, I guess, in terms of today at least, is then the analysis. If we have all of that data, we have very structured data when we do that. We have near real-time data in most cases, but we've also got context data, those other things that have happened before, during and after, for example, allows for a much more detailed analysis of falls across an individual, across a service, across a group, and indeed across the whole sector. That may be analysis of things like how often are falls happening, patterns, but also looking at the severity, the impact of those. What's the impact on the individual in relation to that particular fall? What kind of trends, anomalies, the factors that are affecting, potentially affecting falls? How are we responding to them? How does that benchmark? There's lots of things we can do in terms of analysis, which again, I'm going to go on to in a little bit more detail in a minute. And feeding that back into the care improvement part of the workflow, we can, because we are planning digitally, it is very easy to bring those findings, what we learn, what we understand from that analysis back into the care planning for that particular individual, or indeed any particular environmental or process changes that need to happen across the organisation. And we can also analyse in the same way the outcome of any changes that we make. So we can understand the impact or the outcomes that have happened as a result of us making changes to an individual or across our service. So that's kind of how we're using it now, and how that's contributing in relation to the workflow, if you like. What I wanted to go through now was just a few examples of what that looks like when that data comes out the other end. These are a few snapshots from Nourish, from across various different points. And they are examples of the kind of information that our customers are able to bring out. Really just to illustrate what I mean by that level of analysis. So, for example, here, this is around the real-time monitoring of falls. Because we're recording those things digitally, because that's happening in more or less real time, you're getting a real-time view of the incidents, in this case falls, that have happened, and their progress in terms of a response that needs to happen to them. We can go into the detail of that particular fall, so we can understand what actually happened. We have context around that, real world context, natural language context around that. And we can understand the management of the response. Where are we in relation to our response to that particular fall? Yes, this is very administrative. Yes, it is very much around compliance, governance, care quality, but it is about giving us that confidence that nothing is being missed. We're getting that overview of things that are happening. When we take that to a slightly next level, because again, because we're recording everything digitally, we can get that snapshot of falls across the trends of those falls across time and between services. Incredibly rich information that's coming as a natural part of our care planning and recording process, not something we're actively having to go and do. What you don't get from these snapshots, by the way, is these are largely interactive, so I can navigate through this data to analyze it more. So, for example, as I roll over the number of people with a fall, for example, that will give me a view of that over time and between different services. There's always a look with these around what's changed, because that's the important thing. It's not just the data itself. The data itself isn't that useful. The actual number itself isn't that useful. What is the direction of travel? What's the kind of trend analysis we can pick up in relation to that? And that's giving us a picture and a snapshot, as I say, across our service and between services over time. We can also monitor the risk. So we're monitoring the assessments. Are assessments being done? How much time has it been since particular assessments have been done? And again, the fact that this is all interactive means I can go and look at all of those individuals that haven't had a falls care assessment, for example, for more than 6 months. Why is that not happening? So it enables us to be able to interact, to be able to get that level of data. And this wonderful looking ball chart here, oh sorry, just went on a couple, wonderful looking ball chart here, or I think the technical term is a scattergraph, but still, each of these individual dots on here are an individual within the care of this particular service. And this is looking at a correlation between falls occurrence, so how many falls are happening, and the level of risk that has been identified through risk assessments. And again, what that's doing is allowing me to identify any anomalies. Basically, with this particular one, you're looking at anything above the 45-degree bottom left to top right view, because that is likely to be anomalies. These are people that have either got a very high risk score, but are not falling that much, which is maybe something you want to highlight as a response or as an evidencing of how we've reduced the risk of that particular individual, or the other way that they have a large number of falls but not a very high risk score. So maybe we're not analysing those risks in the right way or understanding them. But it's all around identifying where attention, where intervention may be needed. That's what we're doing with this kind of level. And then we can take that a level further. We can get a more detailed analysis of the falls in a particular service. you can start to identify correlations and trends, again, by navigating through this. If I wanted to see if there's a relationship between injury level and locations of a particular fall, here I'm seeing the locations. I can also look at time of day. I can also look at day of the week. You can start to build up a more detailed understanding of trends and what is happening, and start to then look at some triggers, some causal analysis. Why is this happening, and what kind of impact there may be. These ones in particular really start to get into care and the delivery of care. They're starting to trying to get some analysis of the context of what's happening before, during, and after falls, because we can record other interactions, other things that are happening, whether that's medication, comfort, hydration, nutrition, all other things that are happening in relation to that individual. We can start to understand, are there any patterns of things that are happening pre-fall and things that are happening post-fall. So both of these charts here are showing me what are the most frequent interactions that are happening within 12 hours before a fall happening and 12 hours after a fall happening. So really useful to start to understand the factors, triggers, and impact of falls that are happening. But all of that's pretty much at a service level. Where it gets super useful, super crunchy, is when that comes down to to an individual. So we're now able to navigate down to look at an individual. We're looking at analysis of an individual's falls, looking at their falls risk, looking at their risks over time. The other thing to point out here is these boards don't sit in isolation. They sit with other boards around critical information around medication, around particular conditions people have, their levels of need. So we can use these in combination, but specifically looking at falls risk and understanding their trends over time, and the same levels of analysis happening and the same levels of context, so that we can start to go, okay, well, what's happening with this individual before and after? This one down here is showing me and I can navigate between and say, okay, were there any things that were planned to happen for this person that didn't happen? Are there any missed interactions in that period of time? And this, again, might be giving us some really useful analysis, some really useful clues into the individual factors and triggers and impact of falls for a specific individual. So I just wanted to give, this isn't a product demo. This is just trying to sort of show where digital data is being used. I'm very conscious of time, so I'm going to move on quite quickly. But what that's doing is, from a risk assessment point of view, it means we're better at understanding the needs and risks, and we're better able to share that across the circle of care. We've got better oversight, better timely, and therefore better timely interventions in terms of what needs to happen. We can better ensure an evidence and appropriate response to it. We can better understand the individual triggers and factors that are likely to lead to an increase in falls. And really importantly, on an individual level, we're able to better identify and implement opportunities to reduce the risk and impact of falls for a particular individual. We can see and identify those opportunities to change skills, process gaps, and better evidence those particular outcomes. On that, though, I think we'd be the first to recognise that this is still very much a reactive thing. We're very much looking at historical data. We're looking at reducing the effort in capturing that and analysing that historical data and providing the conditions for implementing best practice response and evidencing that, but it is still reactive. The real world feedback we really get from this is that it's about reduction of the burden and the time that it takes to find and collect that information, which without doing this digitally just probably isn't practical or possible at scale. Bringing all that information into a single place, that single resident view, help cut through the noise, know where we need to focus. And really importantly, making it therefore useful and actionable at an individual level. A lot of this talk of digital and data can seem very systematic, very impersonal, but actually it's about understanding the individual needs, risks, and the individual factors around an individual, so that we can have the space and time to be able to respond and implement that. We also recognise there's a lot more to do, and kind of where we see the next stage and where we see this going. A large part of that's in the analysis, and doubling down, more multifactorial analysis. So bringing into that style of analysis more data around other things, polypharmacy, for example, or other medical issues, other condition issues. What else can we bring into this data to be able to better understand those individual factors? Bringing in some more of the unstructured data. We know that falls are very specific to individuals. How do we bring more of that data into the picture? And how do we do that across the sector a little bit more? So the more data we get, the more people we're able to view that data across, the more information we're going to be able to use. And that then can feed into care improvement by some level of automation. We've always got to be careful with automation. It's useful in certain cases, but we should never let the algorithms take over, right? Most automation is about nudging people to do things and use their professional judgment to be able to implement those. But a level of trigger of a automated response to adapt care based on the triggers for that individual. And that's where, again, it comes back to the monitoring, that if we can do that, we start to not just monitor generic risks, we can start to actually monitor the individual triggers and therefore do much more to predict and prevent falls if we have that data available to us in those ways. So that's how we see the future. And if we implement that, hopefully it's a much more proactive process. It is much more an emphasis on falls prevention and falls reduction. We believe it can help support that improvement culture that Fran's been talking about, and person-centered care, making it far more integrated. I am, again, conscious of time. I'm glad Nuno's not here, really, because he wouldn't have had very long to talk. But this was meant to be Nuno's bit. I did just about get time to pop my little avatar in there to say that I might be picking up on this bit. But really what we just wanted to do here was, we've heard a lot from Fran in terms of how research and traditional research can help us with best practice. And we've just been through quite a lot around how digital and data is supporting that process and can help us be better at falls prevention. But really what we just wanted to have a sort of view on, I guess, is what if we can start to bring those two things together? If we look at a traditional research program, it follows a very structured process, and it follows a structured process for a reason. It has to follow that structured process. It's about rigor, and it's about the integrity of the evidence and data that's coming through. So we go through that flow, and really the important bit, and again, Fran talked about this a lot in terms of the implementation of that on the ground. How do we bring that best practice learning to bear, and how do we bring that to life? Largely through the recommendations issued and the training delivered, which is largely a systematic process within a care environment of us training our care teams. And we tend to do that in a sequential basis to be able to go and do that training. But training is really our most important tool in terms of being able to take that best practice out. The reality of that, or what we're trying to do by that training, is always reduce the level of risk. So we know that if we bring that falls prevention training in at the right point in time, we're going to reduce the level of risk in relation to the overall cohort of people that we'll be supporting. The reality is, due to changes in the care team, due to changes in the nature of risks of those individual residents and generic skills erosion, we know that also that over time that benefit starts to go away and the risk can start to come back again. And we also know that the reality is we're not just looking at a falls risk in isolation, we're looking at all other kinds of risks, and we're looking at all other types of training to support those risks over time, which makes it very complicated. So really the sort of the notion we're putting together is, what if we can bring these two things together? What if we can use digital and data to be able to disseminate that best practice? And we can do that at speed. And that really is around contextual training being part of that digital care and planning process. What if we can start to, and what that means is, if we then support that with the data that we're collecting on incidents, that we're recording that digitally and we're doing that in real time, that we then build up that level of data and at scale, that we can then start to share that data with the research organizations. So we start to bring in the best practice, we get a whole lot of data around that best practice, we put that back into the research process, not into a direct feedback, but into the research process to inform and improve that best practice. We can also look and measure and understand through that data, through that digital impact, the what's happened and the results of that, and what's happening at quite a sector-wide level and at speed, to then also mean that the data is informing and in itself is then feeding back into the best practice, either best practice on a generic level, but also best practice right down to an individual's level, because we've understood this particular individual. So there's kind of a virtuous loop here of the best practice being disseminated quicker, the data that's coming off the back of that implementation of that best practice at a bigger scale and being implemented into research quicker, and then we can bring all of that back into the best practice learnings. And if we do that with a little bit of luck, you get into that continuous quality improvement over time, so we can maintain those falls risks at a low level. Again, sorry, very conscious of time. Thank you. Hopefully that's been informative and interesting to some level. But as I said before, it really is just our view and our observations and some thinking about where we want to go. So it really is important for us to hear, to have any questions and any comments or your own observations that you might want to share about the future of digital for falls prevention. So Adam, I will pass back to you to look at the questions and answers.
Thank you very much indeed. And thank you, Fran, as well. Fantastic exploration of 2 areas there, which is really, really interesting. We have got quite a few questions coming through on chat, which is really, really good. I think, first of all, it would be fantastic if Zach, who's been posing quite a few questions on the chat, if you'd be happy to come on. You mentioned about kind of how we could think about unsiloing this data, essentially, and what you're collecting can generate kind of internal thought around falls prevention, but how can that be opened up to the wider sector? That you could probably pose that far better than me there, but that was really interesting.
Yeah, there is a national requirement for ICBs to coordinate a response locally for an 8 AM to 8 PM falls service in the community. This is very much, so far as I can see, a care home, nursing home offer. The scope for the community hasn't been discussed yet, and I don't understand what the vision for Nourish is in terms of the community model.
Yeah, I can. Sorry, Zach, go on.
That's right. And then what I struggle with is, the reason why I've joined is because I am directly involved in the local plans with the ICBs and ICPs, and I was hoping to get something from the meeting that I can take back to those groups. Yes, from this meeting. However, I struggle to see how it's different to just another care management piece of software that's been adapted to capture falls data to, yes, identify when a fall happened, how it happened, why it happened, what the outcomes were, and thereafter generate an outcome for the care home or nursing home to understand how they can better the service delivery to the individual. I do struggle to understand how that's going to make it better for the individual in terms of the outside multidisciplinary response from the sector, and again what the vision is for the community model, where I don't mean this disrespectfully, but where there is a real issue and the numbers are multiplied. Multiplied. Yeah,
thanks. I'll try and answer those. There's quite a few questions in there, and it's a big topic. But certainly in terms of the wider dissemination of that information and engagement with different bodies, as you've noted, ICBs, ICPs, ICSs, there's a wide variety of requirement for that data. We have various conversations and ongoing initiatives. As always, these are a little bit sticky, fraught with data issues and other things. But we are definitely looking at, and it's definitely an ambition to build the capabilities for that data to be shared at a system-wide level, either for analysis and research purposes, but probably more importantly, to answer your question, in terms of how do we put that data in the hands of other disciplines, other people outside of that particular care home environment who may be having an influence in terms of the provision of care to those individuals. So the answer is there isn't a direct plan to do anything specific in the ultra short term. There is lots happening in terms of conversation around it, as always, and we are contributing our best to being part of that conversation as much as we can. But I take your points on board. It is currently as well, absolutely, as you say, it is now a closed loop in terms of those that happen to use Nourish and within their particular services. We absolutely take it as a responsibility. We need to take that wider.
I guess for me, that's the gap in the market. That's the part that the NHS can't solve at the moment. The ICBs can't solve. The Connecting Care and the hundreds of millions of pounds invested in making things digital still hasn't.
And we can't solve it in isolation either, unfortunately. So it is the combination of those three things. And as we know, those kind of interoperabilities and integrations getting far easier. We've seen things like GP Connect happen very quickly in terms of that being or giving access to things like GP Connect in a much wider way. The work that the PRSB is doing in relation to standardization of things like transfer of care and those more system-wide networks happening. As always, the technology is not the hard bit. Getting the understanding of where that data needs to go into whom and what they're going to do with it is usually the key sticking point.
Oh, thank you very much. Thank you, Jeremy. Thank you, Zach, for your question. There's more in the chat. You're not off the hook yet there, Jeremy. Under analysis of benchmarking, under the analysis sheet, and this is from Ian here, benchmarking was stated. So how are you intending to benchmark, and where are you collecting the data to accurately represent meaningful benchmarking? Yeah. Another big topic.
It is a big topic. Obviously, we can only benchmark in relation to those that are using Nourish in the way in which it is currently being viewed. It is clearly not up to us to publish any of that information in that way. But making a benchmarking analysis available to our customers to understand where they sit. A lot of benchmarking already happens within a group or within a service, right? So that data is kind of there, and understanding that between our different care services are different things happening. Do we understand the levels that we're trying to work through? But doing that in a system-wide way, yes, we definitely have plans to implement that. And again, watch this space. It's not just us. There are others involved in that as well, because what we really want to be able to do is, as a sector, be able to pull that information together. But again, it does require a degree of standardization. So there are conversations around the standardization of falls data across different system providers, so that we can normalize that benchmarking across a wider part. The other thing I would ask for is please get in contact with us as well. Please help us understand what benchmarking you need, because benchmarking can mean lots of different things, and sometimes benchmarking becomes a little bit meaningless. It's sort of trying to, is this level of falls acceptable? Well, I don't know. That's just it can be quite arbitrary. So really getting under the skin of really understanding what we want to benchmark is a request. Please get in touch. More than happy to have those conversations.
Oh, fantastic. Thank you very much. And another one from the chat here, and Fran, I'd like to bring you in, but I think this is for both of you here, around supporting the quality of data that is gathered along the journeys for the Falls Action Programme and within Nourish, and how you essentially kind of built that in, or how you've kind of mitigated loss of quality of data throughout this, because it is very reliant on it, isn't it? So Fran, if I hand over to you first, I'll give Jeremy a chance to just have a quick breathe.
So when we talk about the quality of, you mean the quality of data as a sort of an ongoing aspect?
Yep. It's only as good as what you put in.
well, quite. I mean, and we certainly, I mean, we're a research team, so we look at things like fidelity, and are people using, is there anything that we introduced being used as we envisaged it to be used to maintain that quality, and we will then obviously check what's going into the forms, or what is being written down at the time, and then we will monitor that through conversation and feedback from the from the teams in a very much more analog sort of way than you know, what Jeremy's talking about everything being, you know, obviously digitized and this sort of almost like this big data type approach. We're, you know, we're much more on a sort of personal level, talking to staff at this point. And I think the issue for us as a research team is how we now need to bridge that into everyday use. So and we can learn, you know, from all the it's very interesting to me looking at the questions and looking at because they're things that we need to think about as well in order to sort of get this idea that we know works in one environment to get that so it's a usable tool. And these are all the questions. As far as I'm aware right now, there's sort of a gap amongst Falls data out there about how it's collected. There isn't necessarily a unified way of collecting data, and I know that's being addressed in various research projects and ideas. So yeah, it's there isn't an answer to it yet about how we maintain that sort of fidelity and that quality over time. And I don't know, and Jeremy, I'm sure, will be able to talk about this more, about how the software can help with that. All we know is that training and sort of keeping that sort of that Falls champion role, that having someone who is trained at a different level to sort of guide the rest of the staff is really important. We know that's really important. But how we upscale that, we're still learning.
Okay, I know.
Probably a terrible answer to that question.
Not at all. No, I think that's a really interesting insight, and you know, interesting approach using almost that kind of champion kind of role to roll it out and to actually keep that quality in there. It seems like a really interesting one. I definitely advocate. I think it works really well. I've seen it applied many times. Jeremy, how can the computers help us?
Those darn computers, they're going to catch on, you know. Digital's really good at enforcing stuff. The trouble is we're always battling with this sort of Venn diagram between what's easy and what's right, because the burden sometimes on enforcing certain things to be collected in particular ways on care teams can be just too much, and it's, you know, it's not necessarily what they're there to do. So you're always kind of battling with that. But in general, digital is really good at enforcing that. So if we're digitizing something like the Falls program highlighted by Fran, we just implement it, and we implement it as it's meant to be done, and we can enforce it. If you don't answer the question right, the data's not right. We can work with standards and do work with standards. You know, we're a PRSB quality partner and working with them on a wide variety of standards, as our colleagues across the digital sector, in terms of those kind of standardized ways of collecting data, so that we can do data at scale. Because that's the other thing we're always battling with, a Venn diagram between standardization of data, because we need standardization if we're going to do anything at scale. If we're going to answer Zach's question, it has to have a degree of standardization to it, because that's the only way it's going to work. But we're constantly battling that, and the fact that the environments we all work in on a day-to-day basis are intensely bespoke. You know, it's about the individual and the way they might express themselves or their needs, and the way in which the care team need to operate. So we're constantly battling between that structured and unstructured data. But the quality of the data, I mean, you said it, Adam, it's the shit in, shit out scenario, excuse me. You know, the more committed we are to making it as easy as possible to do things in the right way, and the right level of standardization that can be shared, then that is the future. But I think that's the sensible approach that everyone is taking. And I think now at least everyone understands it is a nuanced argument, and you need some level of both.
And you've provided a wonderful quote then to finish up as we enter the last 30 seconds. And I'm not going to repeat it, because if my mum watched this, she'd be very annoyed. So I'd like to just take this moment to just thank yourself, Jeremy, and Fran, for your insights today. Thank you all for everybody who's attended and posed those questions in the chat. As mentioned at the beginning, the video will be circulated, the recording of this. So we've got lots of interesting thoughts, and that's my summarized final thoughts there. I was hoping to do a little bit more, but time is very much against me. So I will leave Jeremy's quote ringing in your ears, but thank you all for attending, and take care one and all.
Thank you, everybody.